Hello, my name is Susan Walley. I am a hospitalist at Children's of Alabama, University of Alabama at Birmingham, and I'm excited today to talk about tobacco dependence treatment in pediatric settings. So in terms of my disclosures, I will be discussing commercial products, but I don't intend to discuss non-FDA approved uses of products, and I have no relevant financial relationships. So what are our learning objectives today? We're going to briefly review the impact of tobacco smoke exposure on the health of children. We're going to talk about evidence-based smoking cessation interventions, what you can do in your office or your hospital setting to help parents and caretakers quit smoking. We're going to discuss some motivational interviewing strategies, and then at the end, we're going to briefly provide an overview of electronic cigarettes and vape devices, as this is the most common tobacco product now used by our youth. So why does this matter? In Alabama in particular, tobacco use and tobacco smoke exposure is a huge problem, as I know all of you guys know. So in Alabama, the adult smoking rate is 21%. And this is data from the American Lung Association State of Tobacco Control from 2017. This is a really great website for you to gain more information that's specific to our state. I gave a presentation in California a few months ago, and this rate was twice the rate in California. So there are some huge regional and state differences. And more concerning to all of us, the high school tobacco use rate is 35%. That's 1 in 3 of our youth that are using tobacco. And one of the statistics I think is so important for us to remember is that 99% of smokers are going to start smoking before they're 21 years of age. And so that's on us. That's the time that we're responsible for these kids. There are large differences in the smoking rate in adults, depending on level of education and race ethnicity. And I think that's no surprise to any of you, that the more educated you are, the less likely you are to be a smoker. And so you can see that data there, that if you have less than a high school degree, you adults have about a 15% chance of a 15% smoking rate. But if you have more than a high school degree, that rate is about 11%. Same differences are seen among different races and ethnicities, and that's the information that you can see at the top of the screen. So the State of Tobacco Control also grades each state in terms of what they are doing to help smokers quit and to help children not start smoking. And as you can see, Alabama does not make the grade. That we have an F in tobacco prevention and cessation funding, F in smoke-free air because we do not have comprehensive smoke-free policies in our state. We have F in tobacco taxes, F in access to cessation services, and we did make a D in tobacco 21 because in the state of Alabama you have to be 19 to purchase tobacco products, whereas federally the law is 18, and certain states have passed tobacco 21 where you have to be 21 years of age to purchase tobacco products. So we have a long way to go, and I know that you out there can help make this difference. So again, for us, why is this a big deal? I think all of us in our practice see the health effects of tobacco smoke exposure on a daily basis. And just to remind us what a difference this makes, we know that there's about 200,000 cases of childhood asthma that is directly caused by tobacco smoke exposure. Up to 300,000 cases of lower respiratory illness such as bronchiolitis, 800,000 middle ear infections directly attributable to tobacco smoke exposure. We know that tobacco smoke exposure causes low birth weight, preterm infants, and about 430 cases of sudden infant death syndrome. So that's information that I think all of you guys probably feel that you're familiar with, but the evidence is very strong. Other areas that you may not be as familiar with, that again, there's very strong data, is that maternal smoking during pregnancy causes orofacial clefts, premature rupture of membranes, placenta previa, placental abruption. We know that tobacco smoke exposure causes ectopic pregnancies. There is lots of emerging literature about the role of tobacco smoke exposure with behavioral problems, including ADHD, and then other congenital anomalies. We also know that among non-smokers, secondhand smoke causes the risk of being overweight and preclinical atherosclerosis. So lots of disease burden, and in our children, most of the time, they have little choice of whether they have smoke exposure. So fortunately, the news is not all bad. The rate of adult smoking has decreased from 24% in 1999 to 17% in 2014. However, concerningly, 41% of children aged 3 to 11 years of age had detectable cotinine, which is a metabolite of nicotine, which is in tobacco products, of course, in the 2012 NHANES survey. And again, this is a continual theme that there's significant differences among regions of the country, socioeconomic status, and race and ethnicity. So 68% of non-Hispanic Black children were found in this national survey to have evidence of smoke exposure, almost 70%. So that's 15 million of our children. So where are children being exposed? For children, most of their exposure does come in the home. And we know that 20% of children are regularly exposed in the home. And then we also know that exposure to smoke in the vehicle is also very common. 73% of parents report that they did smoke in the car within the past 3 months. So what can you do? We're here to talk about what can be done by you as a pediatrician and your office staff or your hospital staff to help support parents and caregivers who smoke cigarettes. And there's lots of evidence, particularly in the adult population, for the 5 A's. And we'll go through that right now. And the 5 A's consist of ask all parents about smoking, because if you don't know that they smoke cigarettes, you can't help them. Advise parents to quit using non-judgmental messaging. Assess their readiness to quit and their prior quit attempts. You can learn a lot from them talking about how they tried to quit in the past. Assist by offering treatment or referral, and then arrange follow-up. You know, I always add the sixth A, which is advocate for tobacco control measures to protect children. We've already seen that Alabama rates an F in almost all of those areas, and so by advocating for comprehensive smoke-free policies in your hospital or your clinic or your city or state, that can make a big difference. So the 5 A's can be hard to remember, but at the American Academy of Pediatrics, we recommend the 2 A's and an R, ask, assist, and refer, which is basically a shorter version of the 5 A's, which we'll go through now. So ask. We talked about, in order to help, we have to identify. And, generally there are some providers who still have a little bit of hesitancy. They don't want to break a trust, or they don't want to bring up a topic that maybe that parents may have some misgivings about talking about. But studies show that parents expect providers in both a clinic and hospital setting to bring up secondhand smoke. So it's important to talk about it in a non-judgmental manner. So some of the questions that I know all of us, including myself, has said is, no one smokes in the home, right? Is your child exposed to cigarette smoke? That's a little bit better. But both of those have a judgment involved in it. And so the recommendation of the American Academy of Pediatrics is to use the phrase, is there anyone who lives with or cares for your child who smokes cigarettes? And if the answer to that is positive, then you can get more detail. Who is it that smokes? What do they use? Where do they smoke? Is there other tobacco products, such as vaping, that we'll talk about, used? And remember that although, most children are getting exposed to cigarette smoke within their own home, that there are other sources of exposure. If children stay with either parent that are separated or divorced. Grandparents may play a large role in caring for the child. Daycare providers, in cars. Seepage from other apartments is actually something that we're learning a lot more about. Multi-unit housing. We know that children who live in multi-unit housing have higher rates of tobacco smoke exposure just from the smoke seeping in from other apartments. And then third-hand smoke. So since that's a newer term, I wanted to make sure to address that. So this is a picture from some multi-unit government housing that a smoker lived in it for decades. And when that person unfortunately died, when they took down the pictures, you can see there that the residue from years and years of smoking still remained. And it's very difficult, if not impossible, to completely rid that apartment complex or that unit from the smell of that third-hand smoke. And so basically what third-hand smoke is that after the cigarette is extinguished, the residue left over from those toxins can get in, of course, hair, clothes, furniture, carpet, and what happens is those residues can actually reoxidize with the air and then form their own pollutants. So this is, again, something that we are really talking a lot to our parents about, particularly if they feel that if they go outside to smoke, then their child gets no exposure. And that's part of why it is so important not to just ask if your child is exposed to smoke or is there smoking in the home, because we know that third-hand smoke, and I know all of you guys know, just from experiences of getting in the elevator with somebody who's been smoking. You know, they're no longer smoking, but you can still smell that residue. So the next A is advise. We want to be specific and personal, but also non-judgmental. And so again, the verbiage that we recommend is quitting smoking is the best thing you can do to protect your health and the health of your child. And I typically add, I can help you, because that gives sort of that opening to let families know that you're not there to judge, you're there to help. And the next A in the 5 A's is assess. Have you thought about quitting? And I find that this really just moves the conversation much more easily and faster to just go ahead and ask them about previous quit attempts, because we know that 70% of smokers would like to quit smoking, and most of them have already tried. And even if they fail, that's an opportunity to talk about what went well and what didn't go well. So if the smoker says, yes, I have thought about quitting, I would like to quit, I just don't know how, then that's a great opening. If they say, no, I'm not ready, then that's when you can use some negotiation, motivational interviewing, and exposure reduction, which means really trying to focus on them never smoking in the home or in the car. So negotiation over time. You know, although sometimes we don't realize with our patients, with our children, you know, the things that we say do matter. So even small doses of counseling can add up over time. You know, making some really, small suggestions like saying, hey, would you be willing to quit on a certain date or cut down on a certain date? And then talking about past successes with their quitting, even if it was temporary, during pregnancy, or just for 1 or 2 days. So this is when we get to talking a little bit about motivational interviewing. And I love the term, it's not you, it's me. Well, in this case in motivational interviewing, it's not me, it's you. And this technique or this theory really, I think, is best said by thinking of you talking with families and making a plan together more like a dance rather than you wrestling them down and saying you must quit, because we all know what happens when people tell us what to do. So motivational interviewing is a patient-centered, directive way to enhance motivation. So particularly in somebody who is interested in quitting, you want to try to help them figure out how to get from point A, them being a smoker, to point B, them being a non-smoker. And when patients or any of us arrive at an action plan that fits their personal goals and the things that matter to them, whether it's their child's health or financial, which is a very common reason, change is more likely. So the major techniques to think about are using open-ended questions, reflective listening, and showing a lot of empathy, which as pediatricians, that comes natural to us. So we'll go over that in a little bit more detail. So key elements include asking permission to discuss, determining the importance of the issue, and the confidence. So this is a technique that is not just good for smoking cessation, is great for dealing with difficult families, obesity, any other topic, and I really feel like it's been so useful in my practice. Other key elements of motivational interviewing, you want to elicit patients' change language. Again, what they feel is important and what they have done. You want to reinforce that and build on it and help patients develop their own action steps. So some examples are, so when we say ask for permission to discuss, what you might say is, I know it's hard to see your child so sick often. Would it be okay to discuss some ways to help your son's asthma? And as a hospitalist, I use this frequently. I've never had a parent say, no, I don't want to help my child get better. Second is determine importance and confidence. And basically this is determine how important it is in their life and also how confident they are to be a non-smoker. So it's very easy and quick. On a scale of 1 to 10, how confident are you that you can quit? And oftentimes there are, rulers that you can get online. You don't need one, but sometimes some of our patients are very visual. And let's just say they say, well, I'm not confident at all. And I think, my confidence level is a 1 out of a scale of, 0 to 10. And in that case, you would say, well, what would help it get to a 7 or a 10 even? And so it really doesn't matter what the number they choose is. It's a way to further discuss and help them get to where they want to be. Elicit patients' change language, reinforce it, and build on it. So an example might be, since we know that many women quit smoking when they're pregnant and then 80% of them restart, what I'm hearing, what you would say is, what I'm hearing is that you quit when you were pregnant. That's fantastic. Since you were successful before, do you feel like you can quit again? And then lastly, help patients develop their own action steps. Now, again, they may not know what those should be, but that's where you come in, as in that dance, you're helping them with actionable steps. So do you think you're ready to set a quit date? And, again, thinking the dance versus the wrestling, instead of saying you need to set a quit date and it should be tomorrow, you would ask them if they're ready and when that would be. So motivational interviewing is very helpful when we're talking about smoking cessation or any other behavior that is important for change to help their child's health. So getting back to the 5 A's, we're now talking about assist. So remember, we have ask, advise, assess, and then assist. So the major parts of assist are pharmacotherapy and counseling. Those are the 2 components of the most effective smoking cessation interventions. And when you combine those 2, you can have quit rates, particularly in a motivated person, of up to 30 or 40%. So we know that even brief advice to quit by a healthcare provider, particularly a trusted pediatrician, does increase quit attempts. So pharmacotherapy. This is something that I think a lot of pediatricians have a little bit less comfort with. So we're going to spend a little bit of time talking about that. The most important thing to let your patients know is that combining pharmacotherapy with counseling doubles a patient's chance of successfully quitting smoking. The types of pharmacotherapy that are approved as first line are nicotine replacement therapy, which would be the patch and the gum that we'll talk about, and then the non-nicotine replacement therapies include bupropion and varenicline. So nicotine replacement therapy is largely over-the-counter, and the most effective way to use this is actually combining the longer-acting and the shorter-acting nicotine replacement therapy. So an example of that would be the over-the-counter nicotine patch. This is something that anyone can go to, a pharmacy, a grocery store, and purchase. And we'll talk about some ways that your patients can actually access free nicotine replacement therapy. But the patches are meant to be put on every day, and that provides a steady stream of nicotine to help with those physical addiction components of nicotine use. The shorter acting nicotine replacement therapies are the nicotine gum, which again is over the counter, nicotine lozenge, which is over the counter, and then there are two prescription nicotine replacement therapies, which are the spray and the inhaler. In general, I never recommend the spray or the inhaler, since the gum and the lozenge, again, are over the counter and are very effective. So this is a great slide, and the reason is that it really helps explain why nicotine replacement therapy works and what the challenges of using nicotine replacement therapy are. So cigarettes, as you can see in the top orange line, are an extremely effective way of providing nicotine to the body. You can see that huge jump in on the y-axis you have nicotine concentrations in the blood, and immediately when somebody's taking a drag, you guys probably all have seen that, immediately there's kind of this relief because that is fulfilling their nicotine addiction immediately. So you can see that the gum, the 4 milligram gum and the 2 milligram gum are the two more yellow lines underneath the orange line. And the gum provides increased nicotine levels, but not nearly as fast as smoking a cigarette. And then when you go down to the very bottom line, the green line is the patch. So the patch takes a while to start working, but once it's at a steady state, it provides a constant level of nicotine to help with that physical addiction. So the idea is very similar, I think, to asthma therapy, where you have a controller medication that kind of helps you keep at bay, and then you have your rescue albuterol. Same thing with nicotine replacement therapy when you use the patch in addition to the gum and the lozenge. That somebody has a patch on, and that helps their steady state, their nicotine addiction, and then when they develop a craving, then they can pop a piece of gum or they can use a lozenge to help with that immediate craving for nicotine, whether it's from a stressful situation or they're just bored. Those are very frequent reasons that people think about smoking a cigarette. So, I think it's important for us as pediatricians who are going to counsel our patients that we let them know that there are evidence-based, FDA-approved, safe medications in a similar way that we would never, for somebody who has type 1 diabetes, just say, well, if you control your diet, you're going to be fine. They need the medical therapy, the insulin as well. So moving on, what the goals are for nicotine replacement therapy is to provide that nicotine that the smoker is addicted to and be able to reduce their nicotine withdrawal symptoms, because we know that that nicotine is a powerful addictive substance, and people classify it right on the same level of addiction with things like heroin. We want people to use nicotine replacement therapy oftentimes to postpone their smoking. So in the hospital setting where I am, we try to say, I know you don't want to leave your child, try to use a piece of nicotine gum instead of going out to smoke and then missing the doctors, on rounds. There are some contraindications, but they're very few. If the smoker has had a heart attack within the past 2 weeks, if they have worsening angina, a severe arrhythmia, or clearly hypersensitivity to nicotine, which would be unlikely if they're smoking because they're taking in nicotine frequently. So now back to the 5 A's, and the last one is arrange. And as the child's pediatrician, oftentimes you're going to be seeing that family and that parent more than that parent is going to see any other caretaker. And so if you're providing some of the counseling that goes along with smoking cessation, it can be a great time to say, hey, I'm going to see your child in 2 weeks for a return ear infection visit, or I'm going to see your child in 3 months for a well child visit. Let's talk about how you're doing at that time. Of course, you want to always recommend that they go to their own provider, their own healthcare provider, but unfortunately, a lot of our parents, they don't have health insurance, they don't have their own provider. So that is clearly a limitation. But I think it's important to talk about some of the resources that are free in Alabama as well as every other state. And the big one is the quit line. 1-800-QUIT-NOW. 1-800-NO-BUTS is what you might use in California. But this is something that 1-800-QUIT-NOW is available in Alabama. And in Alabama, you at this time will get 8 weeks of free nicotine patches if you call the number and you qualify. And that's about $150 worth of free nicotine replacement therapy to that patient, to that smoker. So of all of the resources, and there are really quite few in Alabama, this is the most important one for you to remember. 1-800-QUIT-NOW, which is the 1-800-784-8669. And so tell your patients about this. In addition to the nicotine replacement patches, there is a trained tobacco counselor who will call that family back and will provide telephonic services and counseling to that person to help them through their journey. So 1-800-QUIT-NOW. So we've talked about the 5 A's and ask, advise, assess, assist, and arrange. And the 2 A's and an R are really just an easier way to remember that. The ask, of course, you want to find out if they're a smoker, and you can ask them if they are interested in quitting or they've tried quitting before. The assist is really the same. You want to give them a message that, that you advise them to quit, and then you want to help them by letting them know about what's available, both pharmacotherapy, which is the nicotine patches and gum, which can be which are over the counter, as well as counseling and the 1-800-QUIT-NOW. And then the refer, again, in Alabama with limited resources, either they need to go to their own provider, or you can continue following them and reminding them how important it is, or the 1-800-QUIT-NOW. So the important thing, I think, for all of us to remember is that under the Affordable Care Act, otherwise known as Obamacare, that if the parent does have health insurance, that if a doctor writes them a prescription, they can get any of the first-line pharmacotherapy to quit smoking for free or with the price of a copay. So, for pediatricians who feel comfortable writing a prescription or have a good relationship with the family, that is a huge benefit that insurance does currently cover. So, smoking cessation interventions, we've already gone through the 5 A's, and the recommendation from the Health and Human Services is that smoking cessation and addressing smoking is one of the most cost-effective interventions in healthcare. Again, prevention. And the American Academy of Pediatrics recommends that pediatricians provide smoking cessation interventions, that it's within the scope of our practice to talk about things that help the child. And a parent quitting smoking is going to help the child in so many ways, not only decreasing tobacco smoke exposure, but we know that children who have parents that smoke are more likely to be smokers themselves. So, hopefully you've been convinced that this is something that you can do in the office, but you may need to convince your partners. So why is it the right time for us to be addressing smoke exposure or smoking in our parents and caretakers? Well, number one, we care for so many patients that have illnesses that are caused or worsened by tobacco smoke exposure. Again, I'm a hospitalist, and in the hospital, the top 3 diagnoses, bronchiolitis, pneumonia, and asthma, are all caused and worsened by smoke exposure. So we have a big reason to try to improve the health of our patients. So some of the data, particularly around hospitalization and around severe disease, is really striking. That we know that children who have parents or caretakers who smoke are more likely to be hospitalized for any cause. They're more likely to be hospitalized and have more severe bronchiolitis, such as getting intubated, being in the hospital longer if they have tobacco smoke exposure. Asthma, so much data, as I'm sure all of you guys know and see in your practice, that children with tobacco smoke exposure are much more likely to be readmitted to the hospital, much more likely to have severe disease. And then a study by Wilson et al., very similar findings related to worsening disease when children are admitted with influenza. So, second reason that it's really the right time is that most of the time, oftentimes, we are dealing with a teachable moment. And so what is a teachable moment? This was a term that came up in the 80s. It is a naturally occurring health event that's thought to motivate individuals to adopt risk-reducing health behaviors. And there's a lot of data on this in adults, such as when an adult has a heart attack and then they say, I never smoked a cigarette again. So we want to use this opportunity, and I like the way Wikipedia defines it. It's a time where learning becomes easiest. And this is a cartoon that you can see of a child that says, let's just consider this a teachable moment. So the teachable moment, we as pediatricians really are privy to so many of these teachable moments. So the birth of a baby. We already talk about many mothers do quit smoking or cut down significantly, but 85% of them relapse after delivery. Again, that's on us. The OBs have helped motivate that mother to quit, but from stress and other things, most mothers unfortunately restart smoking. Child hospitalization, of course, is a teachable moment that we try to capture and really try to focus on helping parents at that time. Long-term health consequences, I think, are harder for some of our parents to really grasp, but 90% of adult smokers start smoking before 18 years of age. And then, as I mentioned, children whose parents smoke are more likely to smoke themselves. And we think part of that is behavioral modeling. They're seeing their parent, their loved one smoking, but we also know there's a role for nicotine priming, that their bodies have become primed to take in nicotine. Financial, I think this is a big driver for many of our parents. A pack-a-day habit costs, depending on where they get their cigarettes and the price, of course, between $2,200 and $2,900 a year. And so breaking that into something that is more tangible, that's $50 a week. And for many of our parents who are living on Social Security or a fixed income, that's a lot of money. And missed work and school due to illness, both themselves as a smoker and also their child. So the third reason that it's the right time to address parental smoking cessation is that they're effective. They work, and I promise that this is only one of 2 diagrams of basic research. So this is a meta-analysis of different studies on parental smoking cessation interventions, and this is both inpatient and outpatient and newborn nurseries. And what you can see is that in the meta-analysis, it favors intervention. So we should be doing these smoking cessation interventions because they actually work to help parents quit smoking. So I think you have seen this slide a couple times. Remember the 5 A's and the 2 A's and an R. So lastly, we're going to talk about electronic cigarettes. And not only because this is something that a lot of pediatricians and a lot of people in general know very little about, but this is something that a lot of our patients and a lot of our parents are starting to use. As I said, that electronic cigarettes, vape devices, as they're more commonly called by youth, are the most common tobacco product now used by our youth. And I just want to repeat that. It is a tobacco product from the tobacco plant. So what you're seeing is some great pictures of sort of this vaping culture, and these can be easily found on YouTube. This is compliments of a colleague of mine at the AAP, Dr. Sue Tansky. So there's some take-home points that I want to pass along to you guys. Of course, this is a big topic, could take up a whole hour in itself, but e-cigarettes are the most common tobacco product used by youth, as I said. This is data from the National Youth Tobacco Survey from 2011 to 2016. And as you can see in the red box, the percentage of students is on the y-axis that are using electronic cigarettes or vape devices has increased dramatically, statistically significant increases basically every year since 2011. And we're excited that from 2015 to 2016, that number has dropped, as you can see from the dark blue to the black line. And we hope that that's related to some of our messaging. But even still, as you can compare e-cigarettes to cigarette use, cigars, hookah, smokeless tobacco, it is still the most common tobacco product used by our youth, and that's worrisome for many reasons. One is that we know that the e-cigarette solution, what's also known as e-juice, and the admissions, which are also known as vapor, have been found to contain ultrafine particles and toxicants, lots of bad stuff, which include nicotine and cancer-causing agents. And these have been shown to have adverse health effects. Basically, almost every day, there are multiple articles that are showing that these products are not safe and they have health effects that may be very similar to cigarettes. The data about how cigarettes kill 1 in every 3 smokers, long-term smokers, took decades and decades to accumulate. And we do not want that same thing to happen with vape devices, that we don't understand the data, we don't get the data, and by the time we do get enough data, then we see, our youth just addicted to nicotine from these vape devices. So what are the health harms? Again, this data is really accumulating very fast, but since we know that e-cigarettes contain the same toxicants and cancer-causing agents found in cigarettes, we can certainly extrapolate that it has many of the same health effects. We know in mouse models that using e-cigarettes do decrease lung function and growth, and what it's thought is that these ultrafine particles that the vape devices will make are actually part of what decreases lung function. The ultrafine particles have been found to have very similar cardiovascular effects. A recent study shows that the risk of heart attack is higher and similar to what you would see in traditional cigarette use. And then we know that there's a risk of injury from battery explosions, risk of poisoning to young children who may really be fascinated by the great flavors like sour gummy and chocolate and ingest them and get nicotine poisoning. The kiosk from the picture on the right that you see really incorporates so many of the concerning issues with vape devices. So basically at the top, you can see the marketing that has, dessert flavors, there's cinnamon bun, there's cupcake, there's candy. And then basically you can see the different levels of nicotine that they're advertising. From the top where it says 0 milligrams of nicotine to the bottom that says 24 milligrams of nicotine. And that's milligrams per milliliter. So we're talking about extremely, extremely concentrated nicotine. And just as a perspective, each cigarette, if you were to actually eat it, contains about 5 to 10 milligrams of nicotine. When you smoke a cigarette, you generally will get, depending on how you smoke it, 1 to 2 milligrams of nicotine. So you can see that, the bottles that have 24 milligrams per milliliter, and those are generally sold in, 30 cc or 60 cc or even up to 240 cc containers. That is a huge amount of nicotine. The other thing of great concern is that even the e-cigarette vape, the e-cigarette liquid that say they have 0 nicotine have actually been found to contain nicotine in them. So some of our teenagers will say, well, I'm just doing it for fun, for the flavors, there's no nicotine. Unfortunately, when we have products that have nicotine, whether that's purposeful or not, then there's still that risk of addiction. So another concern with vape devices is the public health harms. And secondhand vapor has been shown to not be harmless water vapor. We know from the scientific studies that I previously mentioned, there is nicotine and toxicants and carcinogens. And so what you can see here is an advertisement in a popular magazine of a woman telling off smoking bans and saying, I can smoke anywhere. And that was heavily marketed for a while to basically say, I can use vape devices anywhere because it's safe. Well, we know that is not true. And so as I mentioned, we're concerned about youth using vape devices with nicotine and becoming addicted to cigarettes, becoming addicted to nicotine, and then going on to develop an addiction to combustible tobaccos such as cigarettes. And you'll see a scientific study on one of the next slides about that. We have certainly over the past decades really worked very hard to de-glamorize smoking. So a lot of our young kids now say that it's gross, say they would never smoke a cigarette, but the problem is that oftentimes these vape devices, these e-cigarettes, look very similar to cigarettes. And so if they're allowed to use them in different areas that cigarettes are banned, then those children start to believe that that it's okay, and it basically re-normalizes smoking. We know that smokers who use e-cigarettes, whether to quit or not, actually are less likely to quit. And I'm going to show an example of that. And then, as I alluded to, we know that, that there has been a huge spike in young children accessing the e-liquid, and this has caused a huge increase in nicotine poisoning, with even one child that died from an overdose. So the last major point, or one of the last major points, is that we know that e-cigarette use based on longitudinal data leads to traditional cigarette use in our youth. So kids who are using e-cigarettes, even though they say they're not going to use cigarettes, are more likely after a year to be using cigarettes. So this is a meta-analysis that was published in JAMA Pediatrics that took into account all 7 of the studies. Again, like I said, the data is emerging, that showed that high school students who use e-cigarettes were as much as 3 to 4 times more likely to use cigarettes after 1 year. So, and that's one of our major concerns, that e-cigarette use leads to cigarette use. And then the last major point is that smokers who use e-cigarettes are less likely to quit traditional cigarettes. And I think that's important for all of us as pediatricians to know that oftentimes when you ask a parent, have you thought about quitting? Oftentimes you will hear, well, I've thought about using e-cigarettes. What do you think, doctor? And it's important for us to know that the data so far is very clear that smokers who use e-cigarettes are less likely to quit. And so you want to congratulate them, those parents who are smokers, for being interested in quitting, but you want to let them know about the things that truly work and the evidence against e-cigarettes being a smoking cessation device. So again, the American Academy of Pediatrics does not recommend, nor does any American major medical group, that e-cigarettes should be used for smoking cessation. So this study basically says that you're going to be about 30% less likely, and this is a meta-analysis of over 10 to 15 studies, that smokers are 30% less likely to quit smoking. So I like to show this slide and this advertisement to really drive in the point that e-cigarette companies are marketing and advertising directly to our youth. That this advertisement is in Sports Illustrated, of course, from a few years ago, and this is really targeting those young, teenage, 20-something males, saying that this is sexy, and these are the same types of advertising techniques that cigarettes used to do before there were regulations. So I'd like to acknowledge the American Academy of Pediatrics Julius B. Richmond Center of Excellence, as well as a section of tobacco control. If you are interested in becoming an advocate in Alabama in the national setting, please consider joining the section of tobacco control. Dr. Sue Tansky, who's one of my colleagues, and there are some great resources available. To complete the process for CME, please return to post-test and evaluation on the ACHIA website. Again, thank you so much for your attention. Have a good day.